Welcome, everyone. My name is Yasmina Sisarak. Welcome to our second webinar in our fall Healthy Brain webinar series. Healthy Brain webinar series is presented by the HealthMatters program at the University of Illinois at Chicago in partnership with National Task Group on Intellectual Disabilities and Dementia Practices, and is funded by the Centers for Disease Control and Prevention. The Healthy Brain webinar series, the contents are solely the responsibility of the author and do not represent the official views of the CDC. Couple of other announcements. CEUs are not offered for the webinars. Each live webinar will be recorded and available to view on YouTube channel. You will be emailed once that is up. It's usually in about a week. Please use chat box for comments and questions. There will be about 10 to 15 minutes after the presentation for question and answer. I wanted to introduce our speaker today. They will be talking about improving access to home hospital for people with intellectual and developmental disability. Erin Shadbolt started her career as an acute care float pool nurse and then transitioned to a hospice case manager. She went on to earn a master's of nursing from Weber State University in Ogden, Utah in 2010 and has been in nursing leadership since. She launched the Mayo Clinic Home Hospital Program in Eau Claire, Wisconsin in 2020 and has transitioned into a role as the Senior Director of Post-Acute Care for Ascension Healthcare, working to increase access to home hospital care to those throughout the country. Today, Erin will talk about home hospital care has become a growing sector in the acute care world, and significant work is being done to ensure equity in accessing the services. This presentation will describe how a fellow in the Golisano Institute for Developmental Disability Nursing worked to solve barriers for those with intellectual and developmental disabilities in accessing home hospital care in rural Wisconsin. Erin, welcome. We're very excited to have you here.
Thanks so much for having me. Are you able to hear me okay?
Yes.
Perfect. All right, well, we will go ahead and get started. Welcome, everybody. I hope that I'm able to share some background for you on home hospital and some of the work that we were able to do at Mayo Clinic to help improve access and some of the ongoing barriers that I see that still need to be solved to move the program forward in terms of equity. So I was super fortunate that I happened to get an email one day that was talking about this nursing fellowship through the Golisano Institute for Intellectual and Developmental Disability Nursing. I've always had an interest in just generally improving equity and access in healthcare. And in my work in the home as a hospice nurse, I had taken care of a wide variety of people that I had seen were not able to access equitable health care. And I was a hospice nurse. So for those people, it was resulting in them approaching the end of their life. So this was something I was really passionate about. And I'm just so grateful for the opportunity to go through this fellowship. When I was at Mayo Clinic, I was a nurse administrator and I was over the home hospital program. At Mayo Clinic, that program is called Advanced Care at Home. It's actually called that at a few different systems. And so I'm going to talk a little bit about the work that I did there and kind of how that journey went for the program. So the initial goals of the project was really ensuring appropriate identification of home hospital candidates that have intellectual and developmental disabilities. And that included input from those that would be served. So one of the foundations of the program that I went through was really this idea of, nothing for us without us, and how do we gather the voices of people that will be impacted by the services that we're creating. Solving for the relationship between home hospital and community services. So I'll talk a little bit more about that, but it is an ongoing challenge to implement the home hospital program in a facility setting or for people that have Medicaid, and then a caregiver respite program development. So a little bit of background about the ACH program. And really, I just want to start with why. So Mayo Clinic launched their home hospital program in July of 2020. Our program development was separate from the pandemic. That just happened to be good or bad timing, maybe, depending on who you ask. But this was really part of the vision that Dr. Ferrugia, the CEO of Mayo Clinic, had to really cure, connect, and transform. So creating a platform that would allow people all over the world to access Mayo Clinic level hospital care in the comfort of their homes, really working to create capacity, to drive affordability, and to expand the Mayo Clinic reach. The care delivery model is delivered in partnership with Medically Home. For those of you that are unfamiliar, there is a few pretty large vendors in the home hospital world. One is Medically Home, but there are several others such as Dispatch Health and Contessa. Medically Home's model includes a remote monitoring center that is the command center, as well as in-home technology, and then a supplier network. And the supplier network includes all of these things that you can see in the outer ring. So you really have the patient in their home connected through technology to the command center, and the command center is coordinating all of these different services that go into the home. And as you can see, it's a pretty extensive suite of services, and it mimics closely the services that you can get in the hospital setting. This is what the Medically Home technology looks like, and this is a pretty typical setup. We usually talk to patients about, where do you spend most of your time, or where is it convenient for you to access the technology? So that can be the kitchen, it can be the bedroom, it can be, next to the recliner, really wherever people have the space and are most likely to be. The Medically Home model includes a tablet. The tablet is locked down so that the only interface that you can see is this one here in this picture. So it has a schedule with some upgrades. They now, patients can see the schedule for upcoming days. They can press a button to talk to their team, which initiates a video call to the command center. And then there's also a place where they can enter their vital signs or see what their vital signs were, access education, or take a photo. There is also a set of emergency backup equipment. So the Medically Home and Mayo Clinic model of home hospital is a pretty high acuity model. So the technology includes a backup power supply that can run an oxygen concentrator for several hours, a phone. So you can see this phone here. If you pick that up, it dials direct to the command center. That's in case something were to happen to the tablet and people aren't able to get through, or if people just don't want to connect through a video call for privacy reasons, they can connect through a phone call instead. There's a personal emergency response device that's worn on the wrist. Usually that is located in the bathroom. So there is, you can see this little box, there's a call thing to call to the command center through that as well. And then there's Bluetooth enabled vital sign equipment. The supplier network looks like this. So again, like I mentioned, at Mayo Clinic, we have a command center. There's a software platform provided by Medically Home that's called Sasha, and that helps the command center coordinate the supplier network to deliver care to the patient's home. The program at Mayo Clinic allows for people to live 30 miles from the home site of the program. And CMS implemented a waiver program in, I think it was maybe late 2020, that allowed for home hospital programs to start to bill Medicare directly for the services. Most of the time, you'll just hear it called the CMS waiver. And what it says is that a patient has to have a sort of an index ER or hospital stay at an identified hospital. And so for the program in Eau Claire at Mayo Clinic, the identified hospital was the Eau Claire Hospital, and patients could be served in a 30-mile radius from that hospital. But the command center was actually in Jacksonville, Florida for our program. And you can see these are all the services that we were committing to be able to provide to people within that 30-mile radius from the hospital. So, community paramedicine and ARR, which is acute rapid response, courier services, DME, so medical equipment, home health aides, home care services, so that includes therapy and nursing, infusion therapy, labs, medical meals. Those actually in the Mayo Clinic model are provided through the hospital cafeteria as fresh frozen meals mostly. And then there's medical waste and kind of all of these pieces of the supplier network that can be delivered. For the journey of the patient in the Advanced Care at Home program, like I mentioned, with the CMS waiver, patients have to visit the emergency room or have a bricks and mortar hospitalization at the index facility, which for us is the Eau Claire Hospital. That's important because in the region where we're serving, Mayo Clinic actually has 5 hospitals here. There's 4 critical access hospitals, 3 of which are actually within 30 miles of the Eau Claire Hospital, and then the Eau Claire Hospital. So this was kind of an ongoing challenge as we would have people that were appropriate for the ACH program. They actually were in the ER in Menominee or the ER in Bloomer instead of the ER in Eau Claire. And those patients were unfortunately not eligible for the home hospital program. So for patients that were identified in the emergency department as being a potential candidate for advanced care at home, that was called a hospital substitution. And those patients would go straight from the ER home, and they would get acute phase care, which is inpatient level care. Again, this is being paid for under the CMS waiver, so patients have to meet inpatient criteria. They have to go through usual utilization management leveling. So it looks just like inpatient level care. They get nursing and therapies, frequent clinician visits, and in-home diagnostics. And then around day 3, those patients would be transitioned to a restorative phase where they would get continued rehabilitation, help with medication management, patient education, and transition back to their primary care provider. Not every patient would qualify for restorative care. And about halfway through the model, Mayo Clinic actually phased out this restorative phase of care. For bricks and mortar patients, so these are patients that maybe came in and they really were too sick to go home right away. A good example of this is somebody that comes into the hospital with cellulitis and they actually have signs of being septic. We generally don't want to take patients that are actively septic home. So for those patients, we would usually culture the wound where we thought the cellulitis was, start antibiotics, and once those signs of sepsis had improved or were trending the right direction, then we might bring patients home. And that was called reduced length of stay. This is just an example of kind of the difference in care between a typical hospital patient and a patient that is in a home hospital program like Advanced Care at Home. So the hospital is such an interesting environment because we pretty much take away usual schedules, and we very much schedule things based on convenience for the hospital operations. It's not really anybody's fault. It's just the way that it works. So your physician starts rounding at 7, which means that your labs need to be really run at 6. And I would say 6 a.m. is probably a little bit late in a typical hospital for your lab draws. A lot of times those are going to start at 4 or 5 in the morning. And so then you have your physician visit, and that's going to be between 8 and 11. Or maybe later. It just really depends on what is going on in your physician's world. You're going to watch TV, you're going to wait for an x-ray. We're probably not going to let you get up and move around very much. We don't really love people to walk too much in the hospital because we don't want you to fall. So we're going to do a sponge bath in bed. At 4 p.m., you might push the call button, hoping to talk to your physician again. The physician might come by at 5, or they might say, your physician will come by and see you tomorrow. You're going to eat dinner at 6 p.m. and then At 11, the hospital is quiet enough for you to go to sleep, except at midnight, we're going to come in and check your vital signs. So you're not going to sleep for that long. Whereas in the home, we have a very patient-centric schedule. The way that it's usually sort of operationalized is we usually start visits in the home actually around 5 or 6 in the morning, because some people are morning people and they're already up, and that's when they want to get their day going. So we do that for those people. And for people that say, I don't get up until 11, then we're not going to come see you until 11. So we usually, one of the first things in the morning that happens is a nurse or community paramedic is going to come by, and they're going to get the lab draw for the daily labs. They're also going to do a basic assessment. And then there's going to be a physician video visit, probably at the same time that a nurse practitioner or the nurse or paramedic are in the home seeing people in person. Visitors are, of course, allowed and welcomed in your home. We don't really have control over that, but we do ask people to not really leave their home while they're in the acute phase of their hospital stay. We'll have an x-ray. Somebody will come to the home, do the x-ray. We'll have an aide come and help you shower in your home. If maybe you haven't showered before and you need additional support, then maybe we have an occupational therapist come and make sure that you have all the equipment and supplies that you need. You can connect to the physician using the iPad at 4 p.m. You can eat food at home, or we'll bring you food if that's what you want. And then you'll sleep in your own bed, and we don't check vital signs at night in the home hospital. So who is a candidate for ACH? This gets into some really important implications when we start to talk about access for people with intellectual and developmental disabilities, and even those with physical disabilities. So the criteria is that they have to have the right diagnosis. And we actually are at a place within the Mayo Clinic program where it's more like you need to not have the wrong diagnosis. So there's some diagnoses that we don't take into the program for a variety of reasons, but it's pretty limited right now. One example would be somebody that is dependent on hemodialysis for kidney failure. Dialysis has some just very specific Medicare billing implications, and we don't have a good way to manage that yet. So I think we'll get there, but we're just not there today. Clinical stability. So essentially, we need to think that you're not likely to need to be escalated to the ICU. You're not likely to need continuous telemetry monitoring. And usually we don't like to admit people to home hospital if we think that within the next 12 to 16 hours, they have something that they need to come into the brick and mortar for. So there's a lot of things that we do in the hospital that we can't do at home. CT scans, MRIs, we can do basic x-ray. We can even do some pretty advanced ultrasound in your home, but we can't do CT scans. So if we know that you need a CT scan today, you're probably not going home with the home hospital today. We're going to wait until after you have that done. Geography, so you need to live within 30 miles of the hospital. Social determinants. So each program is a little bit different, but for the Mayo Clinic program, they have a social stability screening tool that asks questions like, are there weapons in the home? If there are weapons, do you agree to secure them? Are there animals in the home? Do you agree to secure your animals? Do you have running water? Do you have working electricity? Do you have heat or air conditioning, depending on the weather? Do you have access to support to be able to move functionally in your home? Essentially, we're really screening to make sure that you have a safe recovery environment. But what you find is that what a safe recovery environment is looks really different to every person that assesses that. And then payer. So there has been a variety of changes to this as the Mayo Clinic program has moved along. You know, they're almost 2.5 years into their program now at Mayo Clinic. Initially, there was a very limited payer group. Now it's much broader, including most commercial insurances, most Medicare Advantage plans, all primary Medicare. but at least in my state, I'm in Wisconsin, Medicaid is not a payer. Our Medicaid system chose not to sign up for the waiver, and I'm not sure that full process, but the home hospital program as a benefit is not something that's allowable under Medicaid in Wisconsin. So we kind of go through this list of criteria. We come up with a list of, 5 to 10 patients in the hospital every day. And then we reach out to the patient's physician and say, hey, do you agree that these patients might look good? And if they say yes, then we reach out to the patients, talk about the program, and make sure that they will be interested in going home. And then everything's arranged and patients can go home with the home hospital. There are times when patients may opt out and they can come back to the hospital anytime. One of the things that we've gotten better at over time is preparing people for what it really looks like in the home. On one hand, it's really nice because it's much more limited interruption than in your hospital room. On the other hand, it feels very disruptive to have people coming to your door every hour or two during the day to provide care. So we do have to sort of prepare people that it really is hospital level care, and it's a lot of people coming to see you to provide hospital level care. So I did a evidence review for this project, really trying to get an understanding of, where's the current literature and understanding of the home hospital model of care, hospital care in general for those with IDD, and then any connection between the home hospital model and care for those with IDD, which I didn't find any literature around that. I did find some pretty good information, or at least the beginnings of what I think is going to become a good pool of information around use of like televisits and telehealth devices for people with IDD. So the current knowledge review for the home hospital's actually been around for quite a while in the US, since the late 1990s, and longer than that internationally. So there is quite a lot of literature if you go and look for articles around home hospital. I just wanted to share some of the more recent and well-known authors on the subject. So Dr. Leff in 2008 really did one of the first what's considered a really nice review of the program and the outcomes. So he describes that the home hospital environment is less stressful for family members of those that were hospitalized. And this was kind of regardless of the amount of care that those families ended up taking on when their loved one was in the home hospital. And I thought that was kind of interesting. In 2018, Dr. Levine published outcomes from a small randomized control trial that found that really our outcomes, quality, safety, and patient experience were similar in the home hospital versus the brick and mortar setting. So home hospital might not be better, but it's not worse than the brick and mortar setting. And then in 2020, CMS, as I mentioned, authorized an emergency waiver during the public health emergency. So for those of you that are familiar with this, the PHE is approved through the end of this year. We've been told in the healthcare world that we'll get a 60 to 90 day notice when the PHE is going to be ended. There is a lot of risk in the home hospital world that if the public health emergency goes away, this waiver could also go away. And so the revenue capture will go away, which would be very challenging. Because while we all love this model of care and believe in it, it's ideal if you can get paid for the care that you're providing. So the waiver did set some minimum standards for home hospital programs. Some of the things that were included, I already mentioned. Patients have to come to the ER or to the hospital for a hospital stay before they can be admitted to the program. There's a pretty extensive application process for hospitals based on whether they have had a previous home hospital program or whether they're launching a new one, including some manual reporting that they have to do to CMS. The patients that are in the home hospital program, according to the waiver, they need to have a visit by a provider. virtual or in person each day. That can be a physician or an advanced practice provider like a nurse practitioner or physician's assistant. They need to have a nursing assessment each day. This can be in person or virtual. That nursing assessment needs to drive the nursing plan of care. And then there needs to be 2 in-person visits completed to follow through on that nursing plan of care that's created by that nurse assessment. This can be provided by a nurse or by a mobile integrated paramedic, also called a community paramedic. There's some differences between those 2 terms, but for this presentation, I'm going to use them interchangeably. So that's kind of where we're at with the current knowledge review of home hospital. It exists, and the research that's out there is pretty good. There's been very limited large randomized controlled trials, and actually, kind of interestingly, Mayo Clinic was in the process of trying to do a large RCT when I left the organization, but there's been sort of multiple challenges because when you approach patients to try to randomize and you tell them that if they're randomized, they might have to stay in the brick and mortar hospital, they opt out of the RCT. So it's been a challenge to kind of gather that data, and I think that's been common. So this is a current knowledge review around telemedicine for those with IDD. Like I said, I didn't find really any literature that talks specifically about the experience of those with IDD or the experience providing care for those with IDD in the home hospital. But what I did find is, especially coming out of the initial year or 2 of the pandemic, there is some good literature that is starting to describe what it looks like to provide virtual care for people with IDD. So in the Selleck article, they talk about that it's possible to deliver accessible and high quality virtual care for adults with IDD, but there's limited research on the topic. Lunsky in 2021 found that there isn't one option that's better for those with IDD, but that video and telephone visits can be used to successfully support the care of those with IDD. And then in 2020, there was an article by Tassi that was kind of a very interesting article. It was actually talking about the use of 2-way technology. So something like a tablet in a home that could help increase independence and a sense of safety in those living at home with IDD. So essentially, they took some individuals that had IDD, put a system in place where they could connect to their health team or to their sort of care network, whether that was parents, friends, their community, and it allowed them to feel more independent in their home. I don't remember now which article it was, but one of the things that I did find in literature that I thought was interesting, and also it seems like common sense, but I want to point it out, is that the most effective telemedicine for people with IDD, and I would venture to guess that this is true for all people, is that telemedicine is most effective if the provider that is providing the medicine part of the telemedicine visit is familiar with the individual receiving care. So I think that's a really important piece that really speaks to kind of that relationship and knowledge of the individual. And then this is a review of the hospital experience of those with IDD. Probably not surprising to a lot of those on this call, but McCormick in 2020 found that it continues to be really challenging for people with IDD to feel like they've received respect, compassion, communication, and accommodations from acute care providers. Maloney in 2021 described some essentially what are interventions that we can provide that improves the acute care experience of people with IDD. What are some of the reasonable accommodations? One was care in the home, early discharge to home, and increased access to family members and caregivers, which I think supports this model of care of the home hospital for people with IDD. I also want to just highlight this very, very interesting article that was published in 2020 called How Hospital Stays Resemble Enhanced Interrogation. And essentially, this article took the CIA Enhanced Interrogation Manual and compared it to a hospital stay. So we take you out of your clothes and put you in a uniform. We really we don't allow you to have any control over the environment. We ask you the same questions repeatedly, but without anybody really seeming to care about the answer. And then we distort day and time. And often we don't take really many of your preferences into account. And again, this isn't any one person's fault. This is the system that we're all working in as it's set up today. So my project was really designed, again, on this principle of nothing for us without us. So I reached out to patients and caregivers affected by IDD to get input for the program. And there was a couple of really key things that I got feedback on. One was, I want to know exactly what care I or my loved one will be getting and when. So the convenience of the schedule on the tablet in the home is really great for that. I want to continue my usual activities. So I already mentioned to you guys that what you do in your own home is sort of your own home. We do sometimes put some limitations, like we don't want you to go up or down stairs, especially if they're particularly steep or slippery. But for the most part, people can do their usual activities at home. But you can't necessarily go out to a daily visit to a group center if that's something that you do. You can't go to the library every day because technically you're hospitalized, which means you need to be under the care of the program. So we usually just address that on an individual basis in the plan of care. People told us that they want to know how to access the program and when they could enter. So we created some patient and caregiver guides that are actually up in our emergency room at the Mayo Clinic Hospital here that let people know right away that as they're being screened, there's an option for them to go home with hospital care at home. We also did a lot of work with our case managers in talking to them about the program and letting them know that they should be talking to patients about this if they qualify. Fear of the caregiver's ability to manage care. Again, this is addressed on an individual basis. Most of our patients end up not needing any home health aid support, but we had some people that ended up needing several hours a day, and that was something that we worked to accommodate. And then fear of what happens in case of an emergency. So this really depends on an individual's underlying diagnosis and what's going on that is likely to create an emergency. But for all of our patients, we had emergency plans. Good example of this is we took care of hundreds of people with COVID-19 to finish up their remdesivir infusions at home. We knew those patients were at high risk of respiratory decompensation. So every single patient got an oxygen concentrator. And if they were already on oxygen, then they got the highest oxygen concentrator that we had. So we have emergency response plans essentially for every patient, really based on their needs. Project barriers. So care resources for those with IDD are siloed and difficult to navigate. I've been a nurse now for 15 years, and I've been in leadership in the home care setting for most of that. If I can't figure it out, I'm really not sure how people that need the services figure it out. I have relationships with people in leadership settings. I know people in healthcare. I know people in the community, and it was so hard for me to figure out really basic information around resources. The Medicaid system in Wisconsin has multiple levels of bureaucracy, and I was never able to find anyone that could help me answer some basic questions about accessing Medicaid benefits while accessing the home hospital program, which is really unfortunate and still a barrier that hasn't been solved. And then the electronic health record is not set up for easy identification of those with IDD. So for this project, wanting to make sure that we created access for those with IDD to the program, it's important that you can actually identify people with IDD. And that's very, very difficult in the EHR, as I found out. So project outcomes, overall, I think my project was a success. We created a toolkit to support ACH access in communal settings. So at the time of this project, which was early spring of this year, 12 patients with IDD were served by the program. Half of those had heart failure. Most of the rest had infections. We had one patient with COVID-19. Patient, caregiver, and staff experience was all very positive. Future opportunities, though. One is really working through this partnership with Medicaid to solve for patients receiving Medicaid community services. So the big issue is that if patients are receiving Medicaid family services, which in Wisconsin, we have quite a really a pretty robust family care plan that allows people that would maybe traditionally need to move into a facility setting to live independently at home or to stay in a lower level facility like a group home or an independent living with this Medicaid family care plan, which pays for things like housekeepers, homemakers, private duty caregiving like aides, and sometimes nurses. So for some people that have frequent leg wraps, for example, they might have a nurse that comes out every other day to do that. So the issue is that when you are a dual eligible, so you're on Medicare and Medicaid, and you go into the hospital, your Medicaid services stop because you're in the hospital, Medicare's paying for that. For the home hospital program, you're not physically in the hospital, you are at home. And so to be at home safely, you normally rely on these Medicaid services. So the question really becomes, is there a contractual way for the hospital to pay for these Medicaid services so that you can continue to stay at home and get hospital services? Or should Medicaid kick back in because you're at home, even though you're receiving hospital level care? There is a solution out there, but I would need to talk to somebody that could answer some of those questions. And honestly, I'm just not sure that Medicaid in our state is resourced to start to talk through some of those implications. I think the other opportunity is continuing to work on creating the respite support for caregivers of those with IDD. So this is an ongoing challenge. If any of you work in an acute care setting, you know how difficult it is to access workers, especially aides or housekeepers or anybody like that. And so trying to create a respite program is really challenging in the current worker environment. And then we really need some formal studies. So my project was a very basic entry-level exploration. I mean, I manually reviewed every patient's record for potential IDD diagnoses. Like I said, it's very hard to figure out. That's how I came up with my count. But we really need some formal studies and some formal literature in this realm. This is just a quote from a patient. So being a part of the program truly was a blessing. The program is incredible, and I will certainly miss the interaction I had with the extremely caring and compassionate professionals that took care of me during my recovery. So the patient experience, like I said, has been great. The one last comment that I just want to make in terms of equity and accessibility is that there is a lot of conversation right now in the home hospital community about, are we really improving access to healthcare, or are we making it maybe even less equitable? I told you guys I live in Eau Claire, Wisconsin. Eau Claire is a population of about 60,000 people. It's fairly rural compared to a lot of places. It's not a suburb of anywhere. Eau Claire is the biggest town for a couple of hour drive. So we really struggle to provide access in our area to the home hospital program because we just have very limited resources. So having a patient 30 miles north and a patient 30 miles south and a patient 30 miles east and 30 miles west of the hospital really limits our resources and makes it very difficult to provide this care because we don't have unlimited community paramedics or nurses in the community. So we've seen a lot of success with home hospital programs in a more urban or suburban area it's a real struggle in the rural communities, and we tend to find that those programs are small and somewhat limited in the acuity that they can support. The other thing that is happening is that many systems are using AI algorithms to help identify patients and predict likely outcomes for people that are in the home hospital program. The AI, that's great. Computer learning is really great. The issue becomes if we are not really mindful of making sure that we are seeking out and providing access to all different types of people in our programs, then we start to build computer learning models or AI algorithms that specifically exclude those people. So if you've never served a person with IDD in your program, your algorithm is not going to necessarily include those people moving forward. And so that's a real risk to programs as we're starting to build some of our more advanced algorithms to identify patients. So that is the end of my presentation. I would love to take questions or comments.
Thank you so much, Erin. Please feel free to put your questions or comments in a chat box. In the meantime, Erin, can you expand on just what you were talking about with the algorithms? So with the home hospital, how would you address the issue of access and equity and just use the use or misuse or of the algorithms?
Yeah, that's such a good question, Jasmine. And I've had a lot of conversations with people that are involved in some of this work in the home hospital world. And it's not specific to home hospital. That's just the world I'm most familiar with. I think that there's a few things that are on the radar that people are starting to think about. One is doing a better job coding people in the medical record. That's one of the ways then you can be very deliberate about making sure that the percentage of people being pulled into your hospital at home algorithm that have IDD is equivalent to the percentage of people that are in your hospital in general. So that's one of the things that we look at when we think about inclusivity and diversity in home hospital. We want to make sure that it mimics our brick and mortar, and we want to make sure that our algorithms kind of mimic that. I think the other thing that's really important is that as we're working with the information technology people to build this, that we have a plan for how do we go back and adjust our algorithms as our capabilities get better. So a good example of this is the dialysis thing. So right now, the Mayo Clinic home hospital program doesn't take people on dialysis. So if we don't go back and change our AI algorithm, it's never going to feed us patients with dialysis because those patients aren't in the current algorithm. And so we have plans every month or two to go back and update those algorithms. And we need to do the same for people with different socioeconomic backgrounds, for people with different intellectual, developmental, or physical disabilities, for people with different types of mobility, as we have increased access to things like home health aides and even the Medicaid services. It will be important that we update those algorithms.
Thank you. Was there a difference between service provision between general population patient versus patient with intellectual disability from your study?
There was. So there was a couple of differences. And again, this was a pretty small N and it was very manual. But based on my review, the people that we took care of with IDD generally had more visits per day. So usually they had additional therapy, so both physical therapy and occupational therapy each day. And then many of them had a home health aide at least once a day and often twice a day. more for respite than for true hands-on personal care, although certainly personal care was part of what was provided. The other thing, though, especially with that underlying diagnosis of the infection or heart failure, this group of patients tended to need more than the minimum twice daily nursing or paramedic visits. They tended to need 3 visits a day. Some of this is because a lot of the IV antibiotics that we give in the hospital are every 8 hours instead of every 12. Also, when we are giving people with heart failure Lasix in the home, a lot of times you want to give that, first thing in the morning and then early to mid-afternoon. But we also like to see those people right before bed. And so some of it was just timing of medications. But that is another thing that could really impact access to this program is I went to a conference and talked about the home hospital program and listened to some presentations on some other programs in Wisconsin. And the other 3 programs that presented are providing 2 visits a day, and they don't take patients that need more than 2 visits a day up front, which again kind of limits access.
And the reason they don't take them is because it doesn't, the funding, or it doesn't pay off, or it doesn't make sense in that direction, or why would that be the case?
Yeah, it's a resource issue. So do you have the resources to provide 3 times a day visits or not? And it starts to get really complex to take care of more than just a few patients, but especially if they have more than twice a day visits.
Thank you. Is there, so the 12, I know it's a small number, but with the 12 patients with intellectual disabilities, were they usually at home with a family member, or was it with a direct support professional or caregiver? Can you speak a little bit about that? And what was the difference between sort of the 2
Yeah, so
locations? And is there a need to build capacity among sort of the support people?
Yeah, so what ended up happening for us is that the people that we took onto our program with IDD ended up being people that were living in a home setting. So we were not able to take people that lived in an assisted living or group home setting for a variety of reasons. But one of the biggest reasons is back to kind of that dual eligible and Medicaid issue is if you are in a group home or an assisted living and Medicaid is paying for your room and board, which is really common, does Medicaid pay your room and board if you are technically in an acute hospital stay? And if they don't, then does the hospital pay your room and board? And so there was a lot of contracting and stuff with that. But anyways, we ended up just not taking people. And this was during the height, in many ways, during the height of the COVID pandemic. And so most facilities weren't allowing extra people in anyways. So for most of these people with IDD that we took care of, they either lived independently with a support community, whether that was privately paid or neighbors or family, or they lived with family members. Most commonly, they were living with family members, either siblings, spouses, or parents that were their primary caregiver.
And did you see any need to, so how was the role of that support person? Kind of like, how was it different compared to general population?
Yeah, so that was one of the really interesting things is that the experience of the support person really didn't vary based on things like, was the patient somebody with IDD or not? It varied more on what was their sort of usual support system. So, we took care of a lot of people that their spouse was their primary caregiver, but that they didn't live near children. They really didn't have a community. They didn't go to church. They didn't have friends. They didn't talk to their neighbors. That was a much more difficult experience than the experience of somebody that had a community, had children nearby, had a church community. So there actually will probably be some papers coming out on this, because we did do some formal caregiving experience surveying. This is a really interesting area of the home hospital world, and one that I'm excited to see more information come out on is, what is that experience of the caregiver and how does it differ from the hospital? I think one of the common themes as I talked to people, though, is that being the caregiver of somebody that's hospitalized is very challenging, even if they're in the brick and mortar. You still feel like you need to be there most of the time. You still worry. You still feel like the care is disjointed. You still feel like the care could be better than it has been. You worry about them falling. And then there's a lot of things like delirium is much worse in the hospital. People tend to not eat as well. They tend to not be as socially outgoing. They usually can't move around as much. Like I said, we don't love for people to walk in the hospital. And so there's a lot that's really challenging in the hospital setting, being a caregiver. And then the other thing is like I said, this was during the height of COVID. So we weren't allowing more than one visitor, which made it even more difficult, because now that primary visitor, and we didn't allow visitors to switch out. You got one visitor and it was your primary visitor. That person was it. They were the only person that was able to come to the brick and mortar and provide support to the patient. So it was a different time, I think, for caregivers, regardless of kind of the patient situation.
Thank you. Another question. Let me just look through. When you're looking at different disciplines, what other disciplines should participate, in your opinion, in the home hospital?
Yeah, that's a really great question. So most home hospital programs are partnered with the services that are available through a home health agency. We certainly saw the use of a social worker. I think the program could use a dedicated social worker, to be honest, especially if we want to do a really good job transitioning people to other community services. So we mostly accessed our social workers that worked in our home health and hospice agency for this program. And that was a really good sort of natural match, because we're trying to access community services for our patients. Speech therapy, occupational therapy, and physical therapy were just instrumental. It was so important to have them involved, and every patient got at least a physical therapy evaluation, and most of them also got an occupational therapy evaluation. And that's so meaningful in the home setting, because people often have never had a professional assess their home environment for equipment or changes to make their home safer. The other discipline that I just can't say enough about is pharmacy. Pharmacy was such an important and integral part of our program. They really helped keep patients safe, and they were really crucial for us to try to find ways around barriers to admitting people. So a good example is that a common antibiotic that we use in the hospital is Zosyn. Zosyn often is given every 6 hours. That was more often than what we would usually accept, but we worked with our pharmacy team and they were able to set up a continuous Zosyn infusion so we could take those patients home. So pharmacy was very, very important. And they were important during the acute phase of the hospital at home stay. And then they also worked with us to transition people to a home medication regimen that they were going to be successful with. So, how do you limit the number of times a day somebody has to take medication? How do you get them on kind of the best dose with the least amount of side effects? What's the right way to set up their meds so that it's easy to remember? So they were really, really helpful. The other discipline that I had thought a lot about, but really we hadn't done a great job implementing was spiritual care. I have a personal connection to spiritual care. I'm not a religious person, but when I had my last child, she was in the special care nursery. And I think out of all of the time that anybody spent with me, the 30 minutes the chaplain spent with me was probably the most meaningful. And I think that is a discipline that we really need to find a way to implement in the home hospital model, to make sure that we are providing that holistic care, and also helping people connect to their spirituality in the home setting is really different than the hospital setting.
Thank you, Erin. Thank you so much. This is so very interesting. Have you found that many people, how familiar are people with the home hospital model in your sort of experience?
My experience is probably biased because I hang out with a lot of people in the home hospital community. I think in larger hospital systems, people know about it. Do patients know about it? I think it's very hit or miss, but mostly people don't really know about it, and they don't really understand, I think, the level of care that actually can be provided in the home. And even physicians within our own system weren't always really able to understand how sick people could be and go home safely. So I think there is a tremendous amount of work to be done on sort of public knowledge and understanding. But I would encourage any of you, if you or a loved one ends up needing to be in the hospital, I would ask the question of whether there is a home hospital program. There's a lot of hospitals that do have home hospital programs. And honestly, in healthcare, we're just not always good at change management. And so we're not always good at advertising or making sure that everybody understands the program. So it's always worth asking the question.
Hey, Erin, it's Beth. I loved your presentation. And I have to admit, until I heard your presentation with the Gooden Fellowship, I really had never heard of home hospitalization and had never heard of it for people with intellectual and developmental disability. So I have to wonder if how well people know about it as an option, and I'm not even sure that people on discharge, and I'm thinking of older adults as well as people with intellectual disabilities, how much they even know that they have an option just for home health after discharge, let alone a home hospital model. And I'm sort of wondering your thoughts on how we can get this information out just on an awareness level for people within both older adults and people with disabilities and people with intellectual and developmental disabilities as an option. And maybe I have slept through all of it and everyone knows about it, but I don't think so.
No, I think you're right, Beth. I think it's fairly unknown, especially to the public. And like I said, I think, in the acute care setting, I would guess most people have heard of it, but there is a lot of financial implications to launching a home hospital model. So they're very expensive to run, especially if you work with a vendor that oversees them. They are challenging operationally because you have people that are up to 30 miles from a hospital and you need to deliver 2 visits at a minimum a day to them. And for better or for worse, if I have 2 patients that I'm looking at for home hospital, one of them is a person with intellectual and developmental disabilities, and one of them is a person without, and I can only take one person into the program. Who do I choose? And I think that is a very real challenge right now, that we naturally are creating a system in the home hospital world where it's creating a place where we have to make a decision on who is going to be easier to take care of in the home and who are we going to be able to provide services for in an easier way. So, who is that? That's somebody that has a more stable, more safe home environment. That's somebody that lives closer to the hospital. That's somebody that can read and write and communicates really clearly. And I'll be honest, I worry a lot about that current system, and how do we create a future system that doesn't do that. But I don't know. To answer your question about how do we make sure everybody knows about potential access to healthcare in their community, I don't know. If I figure that out, though, Beth, I will let you know. You'll be the first on my list.
Well, I guess in the meantime, I wonder if this is an option. You talk about your network. If you have like a list of the hospitals that have it, and then just like some really brief questions of how can we access it. That would I think we would be happy to just disseminate that on our listserv so people have it in their mindset that this is even an option.
Yeah, that's a good suggestion, Beth. I'll have to look, because I think that there's a list available on the CMS waiver website. Like, I think you can see the list of approved waivers. But the other thing is there's home hospital programs that are running outside of the waiver. So that adds kind of another level of complexity.
Okay. Yasmina says we have to wrap it up. And
Thank you.
So I'll let Yasmina close shop.
We are at the hour. Thank you so much, Erin. This was very intriguing, interesting, and informative. And please keep us posted, in your future endeavors, what happens. Thank you all for sticking with us till the hour. I just wanted to put a plug in for our next webinar, which is Tuesday, December 6th, promoting direct support professional resilience, synthesizing findings to make an impact. Thank you again, Erin. Like I've mentioned, the presentation has been recorded, and we will be able to put it up